right. So Jeannie, do you want to jump in?
Sure.
Okay.
Welcome, Dr. Norton, to we do this Tuesday lunch education meeting. Today she's going to be talking about skin lesions, which is very important for us, especially in trying to identify some of those before we send them to dermatology. Dr. Norton did her undergrad or her medical school and her dermatology residency at Duke University. Her parents are from Poland. She's born in America. She enjoys traveling a lot and has been to some very interesting places teaching English language. So welcome, Dr. Norton.
Thank you for having me today. All right. And then Joan, how do we put the slides up? Let's see.
Sorry, do you have yours ready to share screen?
Oh, do you want me to? Oh, yeah,
okay,
sure.
I can do mine. I can do mine.
Okay, that works.
Hang on, just have to get it. Let's make sure I have the right one. How does that look?
That looks great.
Okay, let me go to slideshow and make sure it still works.
Actually, will I have control that way?
No, I will.
Okay, sure.
But it's not going to live.
Okay. Shoot, we were so on top of everything.
Yeah.
Let me see if I can actually just pull it up really easily. All right, I'm actually pulling it up.
Okay. I just don't know if it's sharing at this point.
Should.
I can see, oh, well, not anymore. The slides were just up, but.
Oh.
Okay, so this is a learning curve for everyone. This is my first time doing Grand Rounds virtually also.
I'm gonna stop sharing.
Okay.
Now you can share.
Okay, so I'll share. Perfect. All right, just 1 second. And that was the missing piece. All right, let's see. And we're almost here. Perfect.
So, you know, I just want you all to know that we practiced this
We
had it down perfect in our practice session.
We absolutely did. All right. All right, now I'm going to share my screen. Oh my gosh. All right, COVID's making me learn new things too. Perfect. All right, everyone see it?
Yes.
All right, great. All right, so I'm glad to be here today. Thanks for your patience as we set everything up. My name's Diana Norton, and I'm a dermatologist here at Billings Clinic, and I'll be talking about concerning skin lesions. And perfect. I know we've got different people from the clinic, probably some learners of different levels, but my main objectives today, there are 3 main ones. First is just to review the most common presentations of skin cancer, because that's what's walking into your clinic, and that's what I'm treating too. To better identify what's harmless versus cancerous, and to determine whether an urgent referral to dermatology is needed. And then lastly, patients will, bring you special body sites like the mouth or their feet. And so those are tricky spots that I want everyone to be a little bit more comfortable with. I don't have any conflicts or disclosures. And then I just wanted to give you an overview of our department. So we have 5 general dermatologists and 2 specialized skin surgeons who do Mohs surgery. We've also got an excellent team of medical assistants and nurses. And our main goal is just to provide really good care for our patients. And we see anyone from infants to people in nursing homes. So our goal is to provide really good care. So all right, we'll just jump right in. So most common skin cancers, I'm going to talk about basal cell skin cancers, squamous cells, and you can't have a dermatology talk without talking about melanoma. All of my photos are de-identified photos from Visual DX, which is a wonderful database full of images and sort of management of common skin conditions. So if anyone gets a chance to try it out, I highly recommend it. I use it on a day-to-day basis, actually. So first things first, basal cell carcinomas. They're the most common skin cancer that we see in general. And they start off as pearly pink papules. And they're from intermittent sun exposure. So think about your person who's going to the beach every year, gets a sunburn, peels, doesn't wear their sunscreen, and then kind of goes year after year. They often do bleed, and in the center they get this kind of blood crusting like you can see in the photo on the left. They are super slow growing and fortunately very low risk of metastasis. So fortunately, we often have time to diagnose and then manage. And I'm just gonna go through and show lots and lots of different photos of basal cell skin cancers now. Here you can see, and I start off with kind of big context. You see that it's an older gentleman, and then he has a very pearly pink plaque underneath the eye. It's kind of shining, glistening, which is characteristic. We can see that there's enlarged blood vessels, and they have what we call an arborizing blood vessel pattern. So it looks almost like tree branches. And the tricky part with this is, removing it because we have to preserve the function of the lower eyelid. And that's what our Mohs surgeons do when they work on the face. Here we also have another older person, and we're looking at the ear, which is another really important body site. You can see here that it's also still pearly, it's shiny, and in the middle has that ulceration. We call it a rat bite or a rodent ulceration, and that's the part that usually hurts and bleeds. You can see that it's quite large actually, and this part's gonna be really tricky to remove just because it's the top of the ear, and especially for older patients, the ear is really important for wearing hearing aids or wearing glasses, and so removal here is gonna be difficult. This is a different type of basal cell. It's a pigmented version. So basal cells are kind of tricky and can make a dark color that's described as a blue-gray color. And you can see here that at the border, they're making that kind of color change. It is scaly, kind of flaky. And I included this photo. I think it's one of the most important photos in the presentation. This is what we call the positive Band-Aid sign, where you can see that someone has been extensively covering this with a Band-Aid. Patients don't always disclose when they're hiding large wounds or growing skin cancers underneath their bandages. So for anyone that walks into me, I make sure that I remove any and all bandages to make sure there's nothing hiding out. You can see this blue-gray kind of pigmentation here, and it's concerning here that there's a hemorrhagic crusting. So this would definitely warrant a biopsy. So the most important thing is really make sure to remove any and all bandages. We have the story from residency about someone who had seen multiple physicians, including a neurologist, his primary care doctor, and he always had a Band-Aid on his back, and underneath was a melanoma. So patients, it's important that we look. Here's a really up-close version of a basal cell, and this is what I get to see with my special dermatoscope that magnifies things. You can see that it's the rolled borders, the really pearly, glistening. It's got the arborizing vessels, and then it's got the kind of blue-gray kind of globules. That's the pigmented version. So these are all the classic characteristics all in one lesion, and this should definitely draw your attention. This one's tricky. So here you can see that we've got a really shiny kind of spot, but it's really dark, almost black. I think this is one that people would be concerned about in melanoma, and rightly so, because I often am. But this is just a really dark, really black pigmented basal cell. And fortunately, it looks really superficial and very small, so it should be relatively easy to treat, even if it's behind the ear. Here you can see, this area here does not look normal. It's definitely got sun-damaged skin. And then here at the periphery, you can see all the kind of like rolled borders and the abnormal pigment deposition. So this is a very superficial spreading basal cell that's also pigmented. But this is dry, and so you would notice that it looks abnormal. And then this is one of the last ones of basal cell. It looks just like a piece of dry skin. It's got the scaling, kind of just the erythema, and it might be just mistaken as kind of an irritated spot. But history matters here. So if this is a spot that's been present for several months and hasn't gotten better, it's worth considering an underlying basal cell. And I would definitely biopsy this. All right. So now on to squamous cell skin cancers. They're the second most common kind of skin cancer, but they have higher mortality, so they're also very important. They're also pink, but they're scaly and rough. And they're from chronic sun exposure, so a lot of our patients who are farmers, ranchers, construction workers spend all day, every day out in the sun. They often really stay rough and they become painful. They can also bleed. And the danger with these is that they can be much faster growing and they have a higher risk of metastasizing, especially if on the face or the ear. So those are the more high risk locations that we should be aware of. And again, I'm just going to show you a lot more photos. You can see here that this is a very sun damaged hand, older individual, and they've got this kind of crusty pink bump. Oftentimes patients will tell you that it's been there for weeks, it's growing fast, and that it's kind of rough, and then it might hurt. So this one should definitely be biopsied. The hand does relatively well, although the skin is pretty thin in that area, so but the surgeries do heal pretty well. Here we see another older gentleman, definitely a lot of extensive sun damage. In fact, he's got all of the pre-skin cancers or actinic keratoses that we call them. But this spot here in the middle is the more concerning one, where it's got the crusting, and this is the spot to biopsy right here. So this is a squamous cell with an extensive sun damage. Here's a really cosmetically and functionally important body site, the lower lip. We often forget that the lower lip gets a lot of sun damage because it sticks out more than the upper lip, and people are not good about putting on sunscreen on their lips. But you can see this is a hyperkeratotic erythematous papule that has probably been present for a while. And patients will sometimes say it's just a cold sore that's not healing, but really there's a raised portion that's more concerning for the squamous cell skin cancer. And fortunately, the lip heals pretty well with surgery. It does bleed a lot, but then it does stretch really well, so the scars end up looking pretty good. I'm showing you another ear, and I talk about ears a lot because they get a ton of sun damage. Wearing baseball caps just does not give enough protection, and people are not good about putting sunscreen on their ears either. But compared to the basal cells that we saw before, this one's much more crusty, much more scaly, a lot more hyperkeratotic, and fortunately not as big as the other one, but still a pretty tough spot to remove. And the ears, kind of just with the cartilage, don't heal super fast either. And then here we see an older hand, and again, sort of this crusty, scaly, kind of raised spots that would warrant more evaluation. And this is one of my favorites. So this is a cutaneous horn. I don't know if anyone's seen one before. Sometimes people walk in with them, but they're literally a horn that sticks out from underneath the skin. It's made of really thick keratin. Sometimes they can be quite large, and I've seen multiple on someone's back. But the real danger of what's making the horn and what's underneath the horn right there. And so there are three things that live underneath the horn or make a horn. The first and most common is just a wart. Sometimes they just become really thick and raised. The second is an actinic keratosis or a pre-skin cancer that can turn into a squamous cell. And then lastly would be a squamous cell skin cancer. And when biopsying a cutaneous horn, the trick isn't to get the horn, we know what that is, but to really get the skin underneath so we can see the abnormality under the microscope. And then here, just more photos of more rough and crusty pink papules that are likely squamous cells. You see here, the scalp gets a lot of sun damage, especially once there's thinning hair, you don't have such good protection. This is why hats are so important. And you can see here that there's a large ulceration and then kind of plaque component right here that we would biopsy. And so that takes us through a tour of the two most common and really the deadliest skin cancer that we can't miss are melanomas, which I know that we spend a lot of time talking about it in medical school and in our training. So just a refresher, so they're usually asymmetric, they're multicolored, and they're from primarily sun exposure for the most part. Tanning beds are actually a big cause of them, and it's partially genetic, so sometimes multiple family members will have them, or melanomas in certain locations will have more genetic predisposition, but it's mostly sun exposure. Lots of women get them because of tanning bed use. They may bleed, they may sometimes be painful also, and then really looking for the ugly duckling sign. So if you're just scanning someone's skin and you're like, holy cow, there's a mole that looks like an ugly duckling, does not look like anything else on there, that should raise your suspicion for possibly a melanoma. This is one of my favorite pamphlet that I hand out to patients. So if they're coming in for a skin check, I counsel them about melanoma, since this is skin cancer we cannot miss. Or if they have family history of melanoma, I always remind them of how to check their own skin. And I really like it because it's illustrated and goes through like the main warning signs. So it's the A, B, C, D, E. So A for asymmetry. Oftentimes melanomas are not oval or round shaped. The borders are so irregular, you can't trace around them with a pencil. They have multiple colors or odd colors that you don't see anywhere else in the skin. And then anything that's bigger can also be more concerning, but certainly we want to catch melanomas when they're small. And then lastly, E is the most important for evolving. So anything that's changing with time, not so much kids that have moles that are growing with them or getting more bumpy, but it's more kind of older adults that have moles that are new or growing in odd ways. So I definitely counsel my high-risk patients on this.
Dr. Norton, can I interrupt for just a minute? I see that Deanna has a question regarding the, can you shave biopsy the horn?
Yes, so that's exactly what I would do. And in fact, I'll show you I've got a slide about shave biopsies also, but it's to really get underneath the skin so that you get whatever's growing from it. You don't want to shave off the horn just at the top. Is that helpful for the question?
Yeah, I was just seeing how far, I knew not the horn, but how far down in like elliptical versus just a shave versus.
Oh yeah, so I would do just a deep shave so that you kind of see the dermis underneath, like that smooth white glistening part underneath the skin. And you should have a little bit of bleeding once you've done the biopsy. You don't need to gouge super deep though, but just so enough that you get just the flesh underneath. So I would just do a deep kind of scoop. Yep. But yeah, that's the really tricky part, because if you don't get deep underneath the horn, you don't know what was there. This is a very superficial melanoma here that is asymmetric. You can see the border's very regular, multiple colors, kind of this pink, blue, dark brown. Certainly does not look like your normal mole. This should definitely raise suspicion and be biopsied. Here you see that this is lower leg of what looks like probably a younger person. You can see that, yeah, it's, round, but there's kind of 2 shades of brown, and it's just so strikingly big, like compared to the mole that's on the Achilles tendon area. And in women, melanomas are most common on the legs, so it's definitely worth looking closely. Whereas for men, it's on the trunk, probably because men wear swimsuit shorts or take their shirts off to work, whereas women often keep their legs uncovered because of shorts or skirts. So this one would be very suspicious. And then people will tell you like, oh, I've had a mole, it's just a birthmark, it's always been there. But then when you ask them exactly how long, they'll say, oh, for the past 5 years. So it doesn't count as a birthmark if it's only been there for a short amount of time. So that's why I always really get clarification, because people are sometimes misleading in terms of duration of lesions. Here you can see, yeah, this is round, it's pretty oval, but it's just too dark in the middle. There's kind of like a pink color to it. It just doesn't quite look like your normal average mole. And compared to this person's other moles, it probably would not be normal either. Here you can see that, this definitely would draw your attention. It's jagged, it's got multiple colors, it's got protrusions. This would definitely warrant a biopsy. And then this is a hair-bearing site, but you can see that this mole certainly looks very atypical. There's multiple portions to it, multiple colors. You can see that it's bled, definitely not normal and should not be ignored. And then this is the last photo that I'm including, and it's pretty striking, right? Like that's a pretty big melanoma. But people honestly have come in with the size of these that they can't tell you how long it's been on their back, and it's just because they can't really see their back. It's not until like their relative comes to visit and then says, you've got something really big growing. So people do walk into clinic like this. So you've got a suspected skin cancer, whether it's a basal cell or squamous cell or possibly even melanoma. So the question is now what? This is sort of answering the question, the cutaneous horn. I'm sure that some of you do biopsies, which is the same thing that I offer to patients. There's 2 main techniques. Like the shave biopsy is really helpful for bigger lesions where you can kind of really get underneath them and get the whole thing. That's really helpful if you're trying to get more surface area, whereas the punch biopsy is just a cookie cutter that takes a small sample of something. I really like punch biopsies for rashes because they go down all the way to the fat. But for skin cancer lesions, I do a shave biopsy just because it gives us more information. The risk of taking only a small sample of a skin lesion is you don't know how deep that skin cancer could go. So that's why a shave biopsy is sort of the preferred method. Anytime I do a biopsy, I always take really good measurements of the lesion. The reason being is if they need surgery later, we need to know for margins about, definitely take a good measurement. And then the key thing is sometimes it's helpful to take a photo, whether it's through like what we use camera capture that goes to the computer or even the patient's cell phone. So that spot can always be located in the future in case like a surgeon has a question later. So location and size also really matter. But let's say that, you've got something that you're just like, they should see dermatology. Let me tell you about our referral process here at Billings Clinic. So all our referrals are triaged and scheduled directly by our staff. For non-urgent referrals, it's about a 3-month wait time, give or take. We do have openings sooner. Anyone who comes in, I photograph and biopsy the site. I also offer them a full skin check because I figure if they've got enough sun damage to have a skin cancer in one location, I want to see the rest of their skin. They don't always take me up on it, but I think that's something valuable that I provide. It takes about a week or two to get the pathology back. And we do call the patients directly, and then we schedule them for our in-office surgical removal, whether it's Mohs surgery or just a simple excision that I would do. And then urgent referrals. I think this is the big question. So if anything's rapidly growing, definitely warrants an urgent referral. We don't want to ignore anything, especially those rapidly growing squamous cell skin cancers. Functionally important body parts we cannot ignore, like the ear or the eyelid margin or the nose. So that definitely warrants quicker action. Suspected melanoma, we get a lot of urgent referrals for that, and we take care of those. So those are always the appropriate things. And then lastly, for anyone that's immunosuppressed, like on high dose, long-term steroids or some of the new biologic medications, their skin cancer can progress a lot faster and become a lot more deeper. So those people are worth seeing faster, and that's what our staff triages too. All right, so we went through sort of the most common kinds of skin cancers. This is a little bit more of a slightly interactive part. In residency, we used to do a lot of cases, and the question was, is this harmless or is this cancer? Sort of what would you do next? We are socially distanced, so you can't turn your neighbor and sort of, whisper your ideas, but just think about, are you worried about this spot? Would you refer? How would you manage? And then I'm just showing more photos just so everyone gets just familiarity with these cases. All right. So tricky location is the mouth. People will come in, and you're not a dentist, but will still want to know what's inside their mouth. So mouth lesion number 1. You can see that there's an adult coming in. They're horrified that they've got this growth in the top of their mouth, and they're like, I've never seen it before. I don't know how long it's been there. It's asymptomatic though. Just think about if you've seen it before, if it raises any bells, would you do anything for it? And then I have a second photo of a similar spot. This one looks a little bit more protruding though. All right, so this is what we call a torus. And it's totally harmless. It's a hard palate growth. It's just extension of the bone. And actually a quarter of the population has it. So if you start looking for it, you'll really find it. People just don't realize that they're there. But sometimes they'll come in and want to know what it is. And you don't need to do anything for it. They're totally fine. But certainly people will come in for other things in their mouth. So we've got a kiddo here. And so just like I know you see of all ages, we do too. And his mom comes in and says he's kind of got this bump or swelling on the left lower mucosal lip. It seems harmless. Sometimes he bites it, but it has grown bigger. And then I've also got an adult version for someone that's coming in. And he's saying that it's a lot more kind of blue, but really kind of soft and kind of mushy. Nothing ever drains out of it. So the question is, what is this? Is this harmless? Who would you refer to? What would you do? So
the seal just needs a IND.
Yeah. So that's the correct answer. So this is just a rupture of minor salivary glands. We see them in kids and adults. My preference is for oral surgery or ENT, just because they have a lot better experience working in the mouth. Other things that I also send my patients to for either oral surgery or ENT, anything on the tongue or anything on the hard palate, those places are just really hard to get hemostasis on. And so I want people who work in the mouth a lot more to work on those sites. I will biopsy things on the mucosal lip or the buccal mucosa, but those other sites should go to other specialists. Right, so we're still kind of in the mouth territory, so now lips. People definitely come in with concerns for those. So you get a kid whose mom brings him in and says he's got these dark marks on his lips. They've been there for a while. He's kind of getting new ones. They don't seem to bother him, but they just look different. And then I also have the adult version. And you can see here, much more extensive kind of brown discoloration all the way from the vermilion to the mucosal lip. Has anyone ever encountered one of these or seen these on people's lips? All right, so if you have or you do in the future, they're called oral melanotic macules, so just dark spots. They're often multiple, sometimes even on the mucosal lip like I showed. More common in darker skin, but if you start looking, you'll see them. You just need to do reassurance. You don't need to biopsy. And you just kind of monitor. Right. Nails are also a special site. People will bring in nail concerns to us or their primary care doctors, I know. So you want to kind of be prepared for those. So you got someone coming in and said that they have dark streaks on their nails. They extend all the way. They've kind of increased or been there for years. They don't seem to bother them. And you can see here that they've got a wart kind of on the cuticle area also. And then I've got a second person's nails here also. Again, kind of just dark streaks, multiple nails. Doesn't seem to bother them. And so this is longitudinal melanonychia, which are harmless, again, often in darker skin. They can be on finger and toenails though, so keep an eye out for it. But the reassuring parts is that they're pretty uniform in their diameter all the way through. They're kind of one shade of color and then multiple nails will have it. My rule of thumb for nails and lips is that if there's multiple, it's probably not harmful because you're not growing multiple skin cancers in one spot. And here we have a third case of nails, slightly different. This person's coming in, hasn't really sought medical care for probably what's been there for years. Their entire nail is black, and then you can see all the discoloration that's extending onto the proximal nail fold. And then we've got someone's foot also. And so I always look at people's feet because you never know what's hiding out. I know that for diabetic skin checks or diabetic foot checks, definitely keep an eye out. They say, maybe I dropped something on my foot and that's why it's kind of, that to me is not reassuring. We're really thinking nail melanoma at this point. The reason being is that unlike what I showed you before, those are non-uniform, there's multiple colors. And then, yeah, it could possibly be like a subungual hemorrhage, but it involves too much of the proximal skin. And that's what we call the Hutchinson sign, which is more of a invasive melanoma that goes beyond the nail. And this would definitely be an urgent dermatology referral. I've seen a few cases where I biopsied and then had to send to general surgery for amputation of the whole digit. So it can be pretty extensive if people don't seek care quickly enough. All right, so feet, another tricky spot, but I know that everyone sees them in their clinics. Someone comes in, they're like, oh, I think I stepped on like a Sharpie. That's what someone told me once. But you can see here, multiple colors. You're already thinking, holy cow, this doesn't look good. Very big, very broad, does not be. And then here's another person's foot. They have let this go on for much longer, and you can see that it's been ulcerated and started to bleed in certain spots. So you know this is bad. And this is an acral melanoma, and not super common, but we certainly see it every so often. This has a genetic predisposition, and we see it in people with darker skin, but it's very irregular, multiple colors, it might ulcerate. One of the things I always make sure that we rule out before we start going down the surgery route is that it's not a superficial tinea nigra, which creates like a black pigment from a fungus on top of the skin. There have been cases where large parts of someone's foot have been removed with tinea nigra. We want to avoid that, but so this would definitely be an urgent referral. And this is compared to just benign nevi that we sometimes see on people's feet. Moles are allowed to be on feet and palms. People won't notice them for a while and then suddenly notice them all of a sudden. They do look a little bit more jagged and kind of irregular, but that's because the foot gets rubbed in shoes during running and walking, so they're allowed to look slightly different. All right, and I know I'm finishing a little bit early, but this leaves us time for questions in case there's any. I kind of went through a whirlwind of different, all of our common skin cancers, different skin tones in kids and adults, and different body sites. So hopefully this kind of gives you next steps of what to look for in clinic and what to do next, whether you choose to biopsy or refer to us. Any pressing questions that anyone's had, anything they've seen in clinic that's concerning to them? Feel free to use the chat. You can unmute yourself.
How often do you use 5FU for some of the like AKs and Basals and stuff like that?
So I do Epidex treatment for people who have extensive sun damage. So like the squamous cells that we saw on the top of the scalp or on that forehead, I would treat the skin cancer first and then absolutely do Epidex treatment twice a day for 3 whole weeks. They're going to get very red and irritated, but we want to prevent future squamous cell development. So I do that pretty often. The buy-in from the patients is variable. They don't like, it's kind of intimidating to know that they're going to have like red, crusty, oozing skin on their face, their scalp for about 3 weeks. Sometimes I let them follow up with me first, kind of, monitor things and then talk them into it later. But if you feel like you've got great rapport and want to treat with Epidex, then that's definitely a great kind of skin cancer prophylaxis.
Dr. Norton, I think it was a little hard to hear Dr. Guire's question. If you could repeat that. And then also the other thing I thought about is you had talked about there is walk-in appointments available, and how do they access that for the patients?
Sure. So the question that I got about the Epidex is how often do we do Epidex cream, and then sort of what its role is. Is that correct?
Yes.
Okay. So that was the question in case anyone missed that. Oh yeah, you're right. So walk-in clinic, it's on Wednesday afternoons. Patients should call by 7 a.m. There's already like a queue of people calling into our central appointment desk, and they get guaranteed a same-day appointment with Dr. Spenny or Dr. Reck. And it does fill up pretty fast, but it's a great way for if anyone's got kind of like, a spot that they're really concerned about or need a biopsy of a certain thing. That's a great way to get them in. If they need a skin check later or have a much more extensive rash or something else is going on, we'll sort of get them sorted out and get them a follow-up appointment, but it's a great way to kind of get people in if there's like a pretty localized problem. So not so good for the people that got rashes for like 10 years. We want to make sure that we kind of do a new patient visit with them that's not, we have sufficient time, but for like spot checks, those are perfect. And so they just call the appointment desk. That's our 238-2501 number. But we certainly try to get people in. I know it's really hard, but we do work really hard on triaging all those referrals.
So I'd love to come off of mute for just a second. This is Joan, and I just, Dr. Norton has been here actually a year. Like I felt bad because I felt like I was saying she was new, and she's like, I've been here a year. So I know that if anyone from RiverStone could kind of talk a little bit about yourself and the type of patients that you guys see routinely, and where this interaction might be, and who could share some of that, so that she has an idea too, now that when you call her, who you are and maybe where you're calling from.
So I definitely recognize some people's names. I definitely read any referral paperwork that I get. especially for people with complicated rashes. And I do try to send my notes back. I know it's like sending things into a void, but hopefully something gets there.
Yeah, this is Jim Gar. So we have both inpatient and outpatient services. So I know like sometimes you'll be getting referrals from the residents on the service. And one of the questions I had was whether you guys do inpatient consults or not.
So we do inpatient consults here at Billings Clinic. Certainly like the internal medicine teams will call us. We do have a doctor of the day that's designated for any like doctor to doctor or provider provider calls. And then they're in charge of any consults that come in, and they get called in through our doctor line, which now I'm blanking on the number. But when you call the operator and want to speak to a dermatologist, that's who they would connect you to. So there's someone here from like 7:30 to 5 that's always available for any urgent questions or any consults.
Great, thank you.
You're welcome.
Can I ask an off-topic question?
Yeah.
I saw there's new biologic for hidradenitis suppurativa. Is that true?
I know we've got Humira or adalimumab. Which one have you seen?
And the second one I can't pronounce, but I just saw a report for one of my patients who's had tremendous success about it, and I just didn't know much about it and how I just was curious more about that. Such a debilitating disease for patients.
Yeah, and I do see a lot of people with hidradenitis suppurativa, which is really tough to treat. So for a long time, we've had Humira. There's actually new evidence that I read in our journal about anakinra. Is that the one that you're thinking of? There's the
second one you said is what my patient is on.
Well, adalimumab, so that's Humira.
Okay.
It's fantastic. It's an injection that they give every single week, but it really can help control how much drainage or how many painful spots they get.
So it's so interesting that it's such an inflammatory process. I guess I really didn't understand the mechanism of the disease process, I think.
Yeah, so hidradenitis suppurativa, for those who aren't as familiar, people get these big kind of draining sinus tracts kind of in their skin folds, like their armpits or their groin. It can be quite debilitating, but it's more inflammation. It's not so much infection. We do use antibiotics like doxycycline, but doxycycline has a lot of anti-inflammatory properties, and it's not just like killing off bacteria, but the Humira works for that reason. People get such improvement on it, so I think it's, can be life-changing for some people. I've had some patients who haven't had as much success. I still remind everyone they shouldn't be smoking, they should be working on weight loss. They've still got to use their topical medications, but it can really kind of tremendously help some people's skin.
That is so exciting. So I just read a report. I wasn't sure who her dermatologist was, but it was life-changing for her. So thank you for that update.
Yeah, absolutely. So we do have a lot of, biologics that we prescribe for psoriasis. Sometimes it's just the topical treatments aren't enough. So I'm glad that we have other options for some of our other chronic conditions like psoriasis or hidradenitis. All right, well, hopefully everyone's questions have been answered. If anything comes up, please let me know. But I'm really glad I got a chance to kind of show you a lot of different photos and hopefully kind of give you tips and tricks for when people come in for all their skin questions that you've got to address.
Thank you, Dr. Norton. That was very informative. If you want CME credit, please fill out the evaluation that Carrie will send out later. And it's great to know that you do the Wednesday clinic walk-in to send some of our patients so they can get in sooner. And thank you very much.
All right, have a wonderful day.
Well, thank you. We will be back on November 24th with Dr. Michael Belsky in rheumatology. So thank you all, everyone.
All right, thanks for organizing, Joan.
Yep.
Great. Thanks, Joan, for organizing it.
I'll send the link with the recording. Maybe.